some of them voluntarily hit cancer genes. Again, really wanted to validate what we're seeing by whole genome sequencing using FISH. So in this case, FISH is essentially a probe that will sit down on top of a gene, and you literally just count how many dots you see in each cell. So each cell for normal genes should have 2 dots. In this case, P10 had a single copy deletion, so for every copy of chromosome 10, you only had 1 copy of P10. Focal RET amplification, hard to see here, but many copies of RET in every single cell. Again, something that you can see at the cellular level, but also read out directly by next-gen sequencing. I did RNA sequencing as well. This is really where having multiple types of cancer, multiple ways to read the cancer genome is really very informative. In this case, MAD4 had extraordinarily low expression compared to a compendium of matched normals, matched tumors and normals. So in this case, MAD4 was deleted and downregulated. So jump back here, there's this deletion of MAD4, really recapitulated in the RNA sequencing data as well. And on the other end, RET was this is one of the most highest expressors of RET we've ever seen. It's 34 times higher than the rest of the compendium reference set. So very attractive druggable target, nothing even in this cancer type at the time without some sort of genomic analysis. And P10, same sort of thing. It's deleted and expressed at a low level. So you have these 2 pieces of data that really sort of tie the story into a nice bow. This list is helpful because some feel of what genes are active in the cell, but at the time it really makes sense of what the druggable targets were. They basically took all the gene, basically all the copy number data and the gene expression data, and assembled it into a pathway. And this, to this day, is still the way that the personalized oncogenomics program is still thinking about and displaying these data, and that they take a annotated canonical pathway and then they layer on the data from the patient. They layer on the copy number data, they layer on the expression data, and they sort of look at what pathways can have clusters of overexpression, deletion, amplification, etc. So in this case, there's RET oncogene was overexpressed, deletion of this negative regulator of that pathway. This parallel pathway was relatively untouched, so really it looked at the time since RET was overexpressed, the downstream targets on that pathway are also overexpressed. But really, this seemed to be the most important pathway in this gene. Not just because of the RET result, but of all the constellations of genes and regulators, both activators and protectors, all seem to focus on the RET pathway. So they came up with a list. Here are taking all this genome data, it really boiled down into 4 or 5 bullet points. MAPK pathway is important. This is important. What drugs could act on this axis? It came up with a relatively short list, and then there's Sorafenib, Slindax. This is really where you present to the oncologist to say, what could this patient bear? Which of these drugs is actually available? What trials are ongoing? And she chose, and it really worked. So after 4 weeks on sunitinib, one of the 4 drugs on the chart, there's a 22% decrease in tumor size. So here's that original biopsy I showed you earlier, 2 nodes here. It took a month to do whole genome sequencing and all the analysis, so you can see during that month's analysis time, the tumors grew. Started sunitinib right here, and then almost immediately within 4 weeks, you see the same tumor masses starting to shrink. So really this idea of knowledge of cancer genome variation, linking it to a drug, really the concept of the proof principle really appears to be quite promising. And stabilized for 7 months. So they reduced clinically they reduced the dose to reduce side effects. Otherwise, great quality of life, sort of thing where you're thinking about coming back to work. But I started this entire talk talking about the inevitable resistance to targeted therapies, exact same story here. Then after 7 months, or after 4 months rather, the lung mets began to grow, but we had all that genome sequencing data, and we had 3 other drugs that could potentially be used. So actually switched to a combination of sorafenib and Slindax, and again stabilized the disease. So really hitting the same pathway in a different way, or hitting some of the other alterations in a different way, and continued for another 3 months. Recurring disease after 7 months. So really this idea of hitting cancers on a single pathway in a single way with a single agent did not work, certainly in his case, In this case, actually, recurrent disease, not necessarily in the lungs, but actually back in the primary site. So even though we had the tumor removed, that there were some residual tumor cells that were still growing, or potentially metastatic cells from the lung going back and repopulating the primary, something that could be answered with genome analysis, not something that was done here. The other concern, a new nodule in the neck. The lung mets are really starting to progress. There's new metastasis in the lungs. Quality of life is, of course, deteriorating. And the question here, genomically, is what has changed? So when I came, they got another aspirate, so more cancer cells. So in this case, they have the neck mass, something that's very accessible with a biennial aspirate. The exact same analysis, they came up with all the mutations and alterations that they saw earlier, in addition to these additional mutations. None of these are really known cancer genes. They're all missense mutations. They're very difficult to interpret. There's no functional data around what these mutations do. This is really the challenge, especially with metastatic or recurrent disease. It's very hard to link even the function of these necessarily. Most of them back to as cancer drivers. No evidence whatsoever in the pre-treatment biopsy, even at low frequency. If you're looking at the one read in 50 or 60, there's no hint that these were there originally. Did the same idea. They took all the copy number alterations and mutations, mapped them back to the exact same pathway, and now you can, again, see this pathway is now linked. It's just red hot. There's copy number alterations, there's overexpression all over this pathway, as well as this parallel pathway as well. In this case, the tumor's response to inhibition of the RET pathway is just to ramp up RET expression. They have insanely high overexpression of this RET pathway, as well as a parallel pathway to achieve the same biological goal. And this is really this idea of self-clonal selection, or this tumor dynamic that I alluded to right at the start, really in action. You can see in the real data, even just with the paired biopsy. And this is really where there just weren't great treatment options then, or even now, actually. Do you consider a cocktail targeted drugs that have never been considered? It's completely not on the table. You can't just take drugs out of the medicine cabinet and give it to people. What do you do about these multiple pathways? Do you hit RET, you hit EGFR? Are there other pathways that are also active? Completely untested, and there's a real risk of adverse side effects. He was the only one at the time to have this level of genome analysis. We didn't really have nice reference sets like Jeannie has today for what other treatments have worked in patients like him. Could we have detected these resistance mechanisms pre-treatment or during treatment? Could cell-free DNA have been a part of his routine care? It's not currently, but certainly there's technologies that are really coming online. None of these mutations were evident pre-treatment, so this really speaks against the need, against using small targeted panels to monitor these tumors, really the need to sequence even cell-free DNA fairly comprehensively to look for the acquisition of new drivers and mutations. Do you think about serial biopsies or blood tests? This is sort of the state of the art of clinical genomics today. So here's his timeline. Unfortunately, in the end, he did enter palliative care until he died, but you can really see the sort of the promise of clinical genomics to extend life and certainly quality and extensive life with knowledge of cancer genome variation over time. So I'll sort of leave it there, and we can take any kind of questions if there are any. Yeah, I think the way forward is reference sets and bioinformatic algorithms. Exactly. This was a PowerPoint slide that they put together, and they still put together more or less manually. This is sort of a right bioinformatics area for taking comprehensive genomic data and linking that to drug databases, not just for other patients, but also model organisms, cell lines, mice. There are huge high-throughput projects that do pharmacogenomic screening. All those cell lines have comprehensive genomic profiles. I think this is going to be the next step. Now we are good at generating high-quality, high-throughput genomic data from patients, and the 50 oncologists have all met in a room, and I think there's a good process to do it now, and the big opportunity is to think about algorithmically how can we now take patient data and share it across all the centers, but we can't all sequence everybody. We need these huge numbers, but also to essentially build pathways like these. I actually think it's a very attractive way to think about and nominate treatments for individual patients, but I think we need algorithms, and it basically has to scale in order to get big numbers out there. Yeah. Yeah, and I think this is something, the skill set you learn this week, you can do this. You can call variants, you can look at DNA and data. So I think the technical aspect is doable. It's that last mile to, okay, now you have a list, how do you interpret it? That's the gap that needs to be bridged.